Good to be with you, Jim.
Nice to be with you, Ophelia. Feels like
We've,
old times.
yeah, it is like old times. It is like old times. We've worked together for a long time now. My name is Ophelia Dahl, and I'm a co-founder of Partners in Health. I used to be the executive director, and now I chair the board. And my good friend Jim Ansara here and I have been working together for more than a decade, 12 years now. And Jim is the founder and CEO of Build Health International, which is really a fantastic organization that builds infrastructure in all kinds of different places and countries. And I was reminded very recently that we had started working together actually before the Haitian earthquake of 2010, but how quickly we started working together in depth to rebuild after that earthquake. And I just am going to remind, not that you need reminding, but perhaps the group that we're going to be talking to might like to know that together afterwards, the first earthquake in Haiti, one of the things that was missing as part of a health system really was in the public sector, a tertiary hospital that could really respond, a teaching hospital. And we had plans to build a much smaller one. And after the earthquake, we all decided in concert with the Haitian Ministry of Health that we would build the kind of hospital that could respond to an earthquake. And of course, interestingly, now you are, really just back from Haiti and have seen all of this firsthand. But some of those patients that and trauma victims are being transferred to the hospital in central Haiti in Mirbalais that you and your colleagues, many colleagues from New England, helped to build. And I just wanted to remind everyone of that because it feels immensely profound, especially now.
I was just thinking the other day about the Mirbalais Hospital and the conversation that you and I and Paul Farmer and David Walton had in the living room in Port-au-Prince that we were sleeping in right after the earthquake about could we build this community hospital we were planning into a tertiary care hospital. And I remember thinking, wow, that's an audacious plan. I don't know if this will really work. And here we are, 10, 12 years later, and it's just had a huge impact. I'm working now with people who were trained in the emergency medicine program there, in the orthopedic surgical program, and it's really amazing. And I'm very appreciative of everything I learned and sort of was incubated at Partners in Health during those years. So thank you.
The learning went both ways, Jim, as you know, because I think, as you've gone on to build in southern Haiti and faced deeply affected by this earthquake and by other natural disasters, it's that partnership, I think, that's been one of the important lessons for us in this work together.
Yeah, and it's been a very trying couple of years for us in global health. I think you'd agree. There's been many challenges, not starting with COVID, but going way beyond that. Yeah. And it's easy to, I think it's easy for both funders and NGOs and people in global health to sort of start to despair. But there's also been a lot of progress, and I'm just wondering how you view that and how you see that.
Yeah, I mean, one of the interesting things about this work, and of course about being in it for the long term, is being able to see the changes that have taken place. And I think that I often worry about the short attention span that sometimes, because of emergencies, that it feels as though people have to focus on just how quickly things can get done and see results, and then even measure those results. When you and I think many other people who'll be talking with us know that it's really investing in systems that has made the difference. And I think when I got into this work a long time ago, if you had told me that I would be finding even the word systems just one of the best words in the world, because it is precisely that we have all lived with for so long, whether it's a municipal water system or a hospital system, it's all of the things linking together that have made the difference. So, having had this lens into watching how a system is built, obviously glitches all along the way, but then watching it get repaired, watching what's missing, what's not missing, how we can build upon it, and then see, whether or not it's investing in now emergency medicine clinicians. As you just said, there were no residency programs in Haiti only a handful of years ago. Now we have a team that actually is responding to this emergency that is almost exclusively Haitian directed, Haitian led, even as the great sort of gaps in things like the government are obvious. So I would say to those people who understandably are despairing at the moment, that there have been great gains, and part of those gains came because of investing in the whole gamut, not a silo, but the whole gamut. That means finding a partner who can build, even as, and that means building homes and shelters, even if you're basically a healthcare organization.
There's been so many lessons for us collectively over the last 12 years. And I think that a lot of times people are afraid to admit that they're learning as they go. But I've certainly seen Partners in Health evolve, and there is, out of the Mirebalais experience, out of the Rwanda Butaro experience, there was a renewed focus in infrastructure, in, as Paul Farmer says, staff, stuff, systems. And I think that the emphasis on looking at these countries systemically and building this capacity for the long term is really going to make the difference over time. You do have to have a very long-term horizon, and that's difficult for many people, but that will be the difference.
Yeah, I agree. It makes, and I do think that I understand that there needs to be this, important balance between impatience and patience, because that there are so many problems, and I think that you've heard us say that sometimes we're too slow out of the starting blocks. But I think that there's a difference between waiting till you have everything perfect and moving along, and actually making sure that you say, we know this needs to be responded to. We're going to do all we can to respond. And like most humans and most organizations can do two things at once. The old days, the arguments used to be between, shall we do prevention or shall we treat? In the case of HIV, there are similar sets of arguments that still go on between, factions in global health. And I think we have to say, you can do both of those things. We do those things here. We do those things in community medicine. You're never going to say, shall we give someone a lesson on prevention when you know that we also have treatment? And I think that speaks to, we have to have high standards. But I'm also wondering, to move us along a bit here, and when we started talking to each other around COVID and the pandemic specifically, one of the things that we talked about, and as we were talking to you about building, we've talked about building good, safe, well-ventilated buildings, all of that kind of thing. But one of the things that we all thought, I think many of us thought, was that COVID would be the great equalizer. And, I think actually everyone knows that it really hasn't. And I think in many ways, it's affected, unsurprisingly, the most poverty-stricken areas, and exposed those areas in this country, certainly, and in other places around the world, to be really the most fragile and vulnerable, and much more likely to be seeing the worst parts of the pandemic. I I know that doesn't surprise you, and if you want to talk about that, for sure. But I'm just wondering what has surprised you in this particular pandemic.
A number of things have really surprised us. Um, we were sort of expecting the pandemic to hit low resource countries very hard, very quickly, and it didn't. And in part, I think that's because people are outside so much more, especially in really low resource settings, and are more rural and less air conditioning. Um, but I also think that that sort of lulled ourselves in the international community asleep to some degree, and we did not respond quickly enough or strongly enough in terms of strengthening healthcare systems, oxygen capacity, PPE, all those things. And I really fear, especially in sub-Saharan Africa, that the worst is yet to come. I look at what's happened in terms of the surge in India in the last 4 months, and I think about some of the cities in East and West Africa, Kinshasa with 17 million people, Lagos, Nairobi. It's with so much less capacity and infrastructure than in India or other middle-income emerging countries. I'm really terrified of what could happen there. I don't know how you feel about that.
Well, I mean, I fear the same thing without question, and I know that without having all the pieces of a health system, it's going to be difficult. If I think about the stress and the taxing of the most well-funded health systems, certainly right here where we're speaking from in Boston is one of those. If you think about how taxed we were at the height of it, and I know we're seeing a resurgence now, it's very, very worrying. And I think that really for me speaks to why investing in all of the pieces of a health system. The community health part is obviously really important. Having community trace workers, whether it's Ebola, or to find people after an account for people after an earthquake or a flood, having trusted people in the community, that feels as though it's a very important part of the system. But so does being able to feed into clinics and make sure that outpatients visits are possible. And likewise, that needs to go into the sort of the bigger tertiary hospital. And it goes without saying that we and some cities have that very high tech, very superb medicine available in healthcare, but the other pieces less so. And certainly in this country, we have almost none of the community health worker contact tracing ability and therefore public health. So I agree that is a fear, and I think it's why it speaks to investments in whole systems. So I think that though I see, back to our first piece of the conversation, there's a great deal of optimism, a great deal of reason for optimism. I think that there's also a lot more work to do to kind of really bring the whole community into kind of having the same standards and long view. And I am wondering if you feel that there are certain areas, even though we have seen the gains in some of this and being in it as we have been sort of on the ground, you literally sleeves rolled up in the infrastructure, in the dust and the concrete, whether, because of seeing some of these gains, I'm just also wondering, like, what's missing for you in terms of this work in general, and what do you think is getting sort of more attention than perhaps it should, and what's getting too little attention?
That's a really good question. There's a slew of things that jump to mind. I think back to our collective experiences in West Africa around Ebola, and we were so hopeful that post-Ebola there would be real investment in West Africa in terms of healthcare infrastructure, because was so lagging and left so far behind, and that did not materialize. Um, I'm hoping that as we move through COVID, there is almost a Marshall Plan to reinforce healthcare systems and investment in very low resource settings in many of the countries we work in together, because it needs to be a bigger program and more audacious plan than the incremental approaches that many of the multilateral funders have taken over the years. And there has to be investment in the public system. And I think about what has happened in Rwanda um, with Partners in Health as a catalyst, and the development of specialists and how much gains have been made. If that could be replicated and amplified across really the poorest and lowest resource settings, then we'd really be able to make some real progress, I think.
Yeah.
What, you know, um,
I agree.
yeah.
I agree. I mean, just to say that we haven't spoken about this before. Not certainly not recently, but I feel very similarly in the sense that the piece getting the least attention, and it's probably the most difficult to do, and that's why I think groups tend not to do it, is the public sector piece. When we started this work decades ago at Partners in Health, we really wanted to sort of go it alone, because there's no question it's easier as a nonprofit to do that. I mean, we started under the dictatorship of Duvalier. Baby Doc was in power at that point, and we wanted to keep our heads down and stay under the radar, because we didn't want to draw attention to ourselves. When it became clear that you really need to invest in the public sector, otherwise you're really creating a parallel system. And it might be easier, but that parallel system is not going to stay if you or your group or some other group doesn't take it over. We've seen this time and time again. So I do agree that that's the great complexity of our work. And yet, even though I'm using Haiti as an example, even though, as you know, PIH works in 10 countries, including here in the US, we even during a time like this, after an assassination of a sitting president in Haiti, you have such a void. And yet, if you're working locally with the public sector, you often can still have some continuity. You're still saying, we're not going this alone, even though it's easier not to work in many circumstances to do that, but it's to forge partnerships and make sure you've got those partnerships really well buttoned up.
I think that goes back to funding and philanthropy, in that what we've seen during the COVID epidemic, especially from the large multilateral funders, is that because of the complexity of their systems, the lack of nimbleness, they have had to fund in ways that weren't necessarily the most helpful, and they couldn't pivot as we learned more about the disease and how to fight it. For example, in the first 6 months of the COVID pandemic, a lot of funding was pushed towards shipping container after container of bedside oxygen concentrators to low resource settings. And what we learned quickly is that in these countries, two things would happen. By the time people got to referral hospitals, which were far and few between, they would be very, very sick, sicker than their European or American counterparts. And they'd need much more oxygen than a 10-liter or 5-liter per minute bedside concentrator could provide. And also that these were designed for suburban America and Europe, and not for low resource settings, and they simply didn't hold up to dust, bad electricity, humidity. And this carried on for quite a while in the funding community, I think because in part, it's just so difficult to, the alternatives were very difficult. I think also in the philanthropic community, and this I think goes more to this audience, that there is again a focus on results and short-term results that doesn't always mesh with what the needs are in these countries.
Yeah.
Sometimes you have to just take a very, very long-term view and be patient. I know it's hard as a funder with my wife to not look for immediate results, but sometimes that's what's necessary, I think.
Yeah, I agree, and perhaps trusting the groups that you are in, really investing in, doing the work to look at the group and say, is this a group that we trust? Does this group have a good record? Not certainly has made mistakes and will continue. If you find an organization that has no mistakes on record, then look out, I would say, because it's iterative, because it's learning. But I agree with that wholeheartedly. Even this week, I got a message from someone who, again, in all good faith, said that they could find some money for Haiti, but they would like they would like to fund something that we wouldn't be doing if they weren't stepping in. And I think that this, to me, remains a problem. If it needs to be about the funder, just to be a little bit, straightforward, then you're not really thinking about the work itself. And we have been, lucky to find great partners in this work. We often, as you know, don't think about the people who fund our, generational work as donors, but really as partners. So we feel lucky to have found partners and pragmatic partners as well in this work. And it's difficult work, so you better find people that you can laugh with as well. And I think I still have some photographs on my phone, Jim, of you asleep on the tarmac at Port-au-Prince Airport in 2010, after maybe 4 days without sleep, and our plane arrived to take us back. And I think I had to wake you up. But we need to get sleep. But I look forward to the conversation with the group, and know it will be fruitful. And I'm grateful to this Innovation in International Philanthropy Symposium for inviting Jim and me to have a conversation together and to broadening it with all of you. Thank you.
Yes, it's been great to speak with you, Ophelia. We don't do it as much as we used to, and I enjoy it. Thank you.
Thank you.